All right, so I have a cold. You'll see why at the end of this talk. So I have some tissues and water here. And I ran into John during lunch, and he kind of was like, haha, you get them after lunch. And I have to admit that when I first was invited and I looked at the agenda, which had been created by the organizers, I thought, okay, so last year all we talked about was sex, and I'm talking about fertility preservation guidelines and after lunch. So I don't know that I'm going to make this as interesting as some of the sessions last year, but I hope that this at least will be informative. And I have to say that after I heard Jenna speak, you know, it really did make me think how important having really good guidelines out in the community is, because, you know, I think we've said this a bunch of times here that we're kind of, you know, we come together because this is important. We think a lot about how to do this, but so many places don't really have that opportunity. And so, you know, I think really trying to think about how we disseminate good guidelines ends up being really important for our colleagues and our patients all over. So just in terms of disclosures, I work across the street from that very large cancer center in New York City. So now I put things on my disclosure list that aren't even really disclosures. And my goals for today are really to talk about some of the challenges that come with building guidelines, and then to talk, because we have some new iterations of the ASCO and ASRM guidelines, sort of what specifically are in them, and then, you know, maybe if we have some time or the chance to kind of think together about what a wish list for guidelines might be. What would we want to be able to tell everybody to be doing and agree upon? So really, in my mind, Oncofertility, to a large degree, starts with these two lovely women. So Joyce Reineke, you've seen in various points here, but we haven't really noted that in 2001 with Lindsay Beck, she started Fertile Hope, which really, to a very large degree, kind of launched all of this effort. And again, I think the other reason to kind of acknowledge them is that really in the end, what we're doing is for the patients. And they really took this issue and said, this is important to us, and we're going to put it on the map. And so just to note, of course, since it is Oncofertility, here are Joyce's gorgeous girls who are now freshmen in college. So really a testament to the work that everybody does here. So in 2005, the first set of guidelines came out. They were published by ASRM. They've been updated twice since then. In 2006, ASCO came out with their first guidelines, and the Oncofertility Consortium really came together to say, how are we going to approach this and treat this as its own entity? And here we are in 2008, and sort of everybody's jumped in the game with the various guidelines, and this is just a small example of the number of organizations that have published guidelines. So what do we really expect from guidelines? So importantly, we want to have them disseminate evidence-based practices. So an important role of guidelines is to review what the evidence is out in the field. When we're lacking in evidence, which happens not infrequently, it's an opportunity for experts in the field to provide their opinions and experiences to help answer some of the thornier questions that we face. What we really want to try to be able to do is standardize practice across institutions, and a large reason to do that is to reduce disparities among individuals. So we've already talked here about how, you know, sites that have navigators really have a very different experience from sites that don't have navigators. And so thinking about what those you know, differences could be is really important in trying to ensure that all of our patients are being exposed to the same kinds of opportunities. And then Dr. Quinn actually kind of reminded me of this yesterday, and it's kind of fascinating, but really many guidelines serve as a benchmark for insurance coverage. And Oncofertility is one of the areas where that's really been a tough nut to crack. That despite all of these guidelines that we have, it still is a battle to get insurance to cover these procedures. And, you know, I think even in some of the discussions that we've had today, it is just so clear that having cost be a part of this is a huge barrier for what we do. And that as important as the technologies are moving forward, that really having the opportunity to pay for these services for patients is just of critical importance. And so the fact that we're kind of in this insurance reform time period, I think is amazing and really speaks to the hard work of a lot of people. So the thing, though, that's interesting about guidelines is that sort of by definition or by necessity, they're looking backward, right? So all of these things are things we talked about yesterday, some even very specifically. I had a picture of a mouse in a Petri dish, but then I had to take it out because no more Petri dishes. So, right, and this is kind of where we want to head, but really what guidelines do is kind of tell us where we've been. So what do we know up until this point? What are the things that we really feel comfortable saying across the board? These should be standard of care. And so for that, we really rely on studies that have been done to help inform us of what information is included in that. But hindsight really isn't always 20/20, right? So the quality of evidence is often quite questionable. There's a lot of subjectivity in evaluating data in small studies and sometimes even large. And I guess my other disclosure really should be that I'm married to a biostatistician who actually works at said cancer center across the street from where I work. And he would say there's subjectivity on the clinician side sort of in every study that they're evaluating, right? And what we evaluate are the published manuscripts. And what goes into that, could be a whole array of information, including, as we all know, negative studies that sometimes don't get published. And so, this view that we have in terms of what is out there is what we rely on, but it isn't necessarily telling us the whole picture. There's lots of variations in methodology. And then really the lens that you look at the data at makes a huge difference. Are you an oncologist? Are you a reproductive endocrinologist? Are you a social worker? Can really, impact actually, even though we're saying, it's data, what the outcomes are. So really this variability has been recognized in the late effects community within pediatric oncology, and there's been a big effort to try to harmonize guidelines across the sort of pediatric and adolescent cancer survivor groups. And this is for many things. It's not just for fertility, and we actually just started a working group to look at obstetric outcomes, which individuals in this room are involved in. Many people have been involved here in evaluating the evidence in this group. And really what they're saying is we want to look at what is out there and create a common vision for what we should be providing to survivors. And we don't want to, these things are very labor intensive. We don't want to duplicate efforts. How can we really improve care? So this is sort of the schema that the harmonization group uses for every guideline. The first thing they do is look for concordance and discordance among the guidelines that exist. They pose the clinical questions, and then they identify and summarize available evidence. So this is, again, sort of the process that it goes through, and it's really pretty extensive, and it takes a couple years, which is also important to know because that means the literature you're reviewing is already going to be, not the most up-to-date. So, you're asking your questions, you're looking for a literature review. These literature reviews and the abstracts that get screened can be in the thousands. Many of them are not relevant, but they have terms that bring this up. And then if there's uncertainty, the full text is looked at, and then we create an evidence table. I'll show you what one of those looks like. And then there's, among sort of a group of individuals that come together, a discussion of all of the evidence to come up with recommendations based on the evidence that's put together. So this is what an evidence table looks like, and I'm just showing it to sort of, this one isn't even one that is enormously complicated, but just to show how much really goes into evaluating a single paper to decide whether or not it can be included in a guideline. So you're really looking at who's in the study, what kind of interventions, what were the outcomes. And so this is not uncommon. So you can see up here 22 patients, right? So a lot of the studies that we look at to make these kinds of recommendations are based on studies with very, very small numbers, which goes back to what we're going to do with the So the first part of this, so we're working on finalizing those recommendations for fertility preservation. That will come out in the near future. But the first part of this effort, specifically in fertility preservation, was really just to look at the quality of the guidelines that exist currently. So there's an established way to actually appraise guidelines. These are the domains that they look at, and they basically ask of each study, how well did you do in defining your scope and purpose? What was the involvement of the stakeholders, and kind of going through. There are like 23 items across these domains that are evaluated and then applied to each of the guidelines. So this is a table, that shows the results of which guidelines that were looked at met high criteria. And what that meant is that they had greater than 60% concurrence with those 6 domains that I showed you. So there's about 25 guidelines on here, and 8 made the cut. So, I think that also speaks to the fact that we have to realize that there's a lot of information that's out there for healthcare professionals, for patients, for advocates, that maybe really hasn't had the rigor applied to it that we would expect. So then they also asked, they came up with 5 key questions, and then applied those to the high quality guidelines that existed to say how much concordance or disconcordance across these guidelines existed. So just to say, concordance basically means you're offering the same recommendation, and the definition of disconcordance is quite broad. So it really was, are the recommendations different? Are they not included at all? So that maybe doesn't exactly capture that you disagree, but it could capture that it's not as important as some of the other guidelines consider it to be, or if only one guideline points something out as a recommendation. So there were a number of ways you could be discordant. But with those definitions, the discordance was really quite remarkable. So I'm listing here the concordance rate, so only 12.8% of the total items were concordant across these 8 guidelines for females and 11.4% for males. So again, that's part of what this effort is doing, is to say, we want these guidelines to be 100% concordant. We want people to agree across the board. So these are the current new guidelines that we have. So again, ASCO just came out with their 3rd iteration. ASRM, these are both 2018. And I'm going to go through these, and this was just interesting because it was some recommendations from an expert meeting that provide some other interesting perspectives. And so what I want to do is just go through these guidelines and apply these questions that were asked. So one thing I do want to, who should be advised to receive fertility preservation? In retrospect, I think is a sort of interesting way of asking that question. And then there are a number of different things that people really are getting at, part of which is really what is your risk for infertility? But it's really not only that, but that really tends to be, not exclusively, but a lot of what gets focused on. But I really just want to point out here that when we look at sort of definitions of infertility or of risk, and some of the prior iterations do have more details in this, but I really just focused on, because these are the publications that are out there now. So ASCO really says, being at risk for infertility due to anti-cancer treatment. So, that's not the most descriptive way to sort of explain it. And I'm not faulting ASCO for that. I think that really comes out of that it's still hard, except possibly at the very high end of the spectrum, to define our patient population, where they are in terms of risk. ASRM gets a little bit more into detail, noting surgery, RT, chemotherapy, dose and age dependent. But again, so it speaks a little bit to sort of individuality, but not a lot of detail. And the expert panel kind of asked the question in a different way, which is, should all patients be referred to a fertility unit before initiating anti-cancer treatment? And the answer for them, in short, was no, that referrals should really be individualized. And they raised some of these, not all of these, but I think, and tomorrow morning, led by Dr. Meacham, we're going to have a conversation about really trying to explore what factors go into risk and how we can put that together in a composite for individuals. So we're all, very clear, I think, that exposures matter, your age at the time that you're considering undergoing fertility preservation. Your age at treatment, when we're looking at the full spectrum from children to adulthood, really matters. I think risk of relapse does come up, but I think it really ends up being a very important factor. I think we do a better job thinking about that for males than we do for females, in part because sperm banking is easier to initiate. But the fact that you might later on get gonatotoxic therapy, even if your upfront therapy isn't going to cause it, is a really important factor. And then at some point, genetics, I think, is going to play a bigger factor. Are there individuals who metabolize drugs differently? Are there individuals who already have some predisposition in terms of infertility that we don't yet understand? And all of those things, in terms of coming together, but we're certainly not there yet, but I think important to keep in mind. The expert panel also notes the idea that the no is in part related to the fact that there is a subset of individuals who really probably don't have enough of a risk to be, have a referral or have a more in-depth conversation, other than talking about what we understand about what their treatment is, but really referring them on to have some kind of intervention, and that those are particularly the younger kids with low risks of infertility from their specific treatment. But again, that the individual's idea of what risk is really important, and in the idea of sort of giving knowledge to the patients, which is what really came out of the last talk, that really anybody who wants to talk more about this, explore these ideas, should be given that opportunity. So what fertility preservation methods should be used? So these are pretty straightforward. Here's my favorite picture ever, sperm bank. So sperm, embryos, oocytes, so these are all, everybody agrees, these are standard methods that can be used. And this asterisk is just here because this is really, both of the guidelines note that this is the first time that the oocytes are really being represented as standard of care. And then ASCO just makes this qualifier in terms of aromatase inhibitor-based stimulation in breast cancer patients. But this is pretty straightforward. Tissue, both testicular and ovarian, everybody agrees and puts the title experimental on it, but sort of the takes are a little bit different. So ASCO does note that it needs to be confirmed whether it's safe in leukemia patients. And they note that there's sort of data out there, that there's activity that really may make everyone take a little bit of a different look at this. Interestingly, I thought ASRM is really the one that says it should only be offered as part of an IRB-approved research protocol, and that's the terminology that they use in the manuscript. The expert panel talks about best candidates, so prepubertal girls as that being the only option. If you really can't delay chemotherapy, and if they've already received chemotherapy. They also note, though, that because of the importance of ovarian reserve in terms of utility for the ovarian tissue, that if you're over 40 or you already have reduced ovarian reserve for some reason, that you would not necessarily be a candidate, and that there is a concern for reintroducing malignant cells, as ASCO notes. So both ASCO and ASRM talk about ovarian transposition and conservative gyne surgery as methods that are important to continue. And then I think, so I was looking through my slides and I thought the number of words that are on the page are definitely related to the amount of controversy that relates to this, because I went back and I was like, yeah, those are just pictures. And here we have a lot of words. So gonadotropin-releasing hormone agonists. So what everybody agrees is that the data is conflicting, but where that takes everyone is different. So ASRM says the data is conflicting. You should, and I think the other thing that everybody really agrees is that nobody should ever say this is your form of fertility preservation, outside of talking about other methods. So that really exists across the board. So other fertility preservation should be offered. That meta-analysis in some of these studies really have shown efficacy in breast cancer patients, that there has been a study that didn't prevent primary ovarian insufficiency in patients with lymphoma. And then, so I know there are two authors in the room of the ASCO manuscript, but I'm just going to read this because I feel like this really reflects the agita that this issue brings to everybody. So ASCO says the panel recognizes that when proven fertility preservation methods, i.e. oocyte, embryo, ovarian tissue, are not feasible, and in the setting of young women with breast cancer, gonadotropin-releasing hormone agonists may be offered to patients in the hope of reducing the likelihood of chemotherapy-induced ovarian insufficiency. However, they shouldn't be used in place of proven fertility preservation methods, right? So, I mean, you can just I just imagine everybody in the room, being like, how are we going to say this? And so I think, again, this is really a huge issue that we really just don't have answers to, but it's important, I think, to try to have answers because obviously it's something that, all things being equal, is fairly easy to provide to patients. So ASCO also, and this is part of the issue we have, I think, with the evidence. So these are a number of the randomized controlled trials. They're primarily in breast. There have been, there's one more study also in lymphoma. The follow-up is actually, I think, pretty good. Excuse me. But really, most of these have non-significant effects, other than the POEM study by Dr. Moore. And so despite what you have to sort of agree is a reasonable effort at trying to get patients enrolled, although if we look here, the numbers are still small. And Dr. Moore's study, I mean, that was really like an international study that went on for quite a number of years. And so it does speak to how hard it is to do this kind of clinical research in this population. So the effort, I think, really actually has been there, but it's been sort of disappointing, I think, in terms of the results that we have. And this is just a summary also of some other guidelines, and their recommendations are all over the place in terms of, yes, this is something that we should do, no, this is something that we shouldn't do, maybe we should do it in subsets, again, sort of all over. So the expert panel really comes out and they say it should be considered a reliable strategy, excuse me, at least in breast cancer patients. And I think that there are, in that community, I think that has really been taken up much more as a recommendation. However, even in that document, 4 of the experts disagreed with this statement and said that they still consider the strategy experimental. So that was like a footnote under that. So there we are. So when should fertility preservation be discussed and initiated? So as we'd all expect, everybody recommends that it should be discussed at diagnosis. There are a couple of additional things that are pointed out. This issue of whether you can do sperm banking after chemotherapy has been initiated, I think comes up a lot when it isn't addressed early enough. But they specifically state that the sperm has a potentially higher risk of DNA damage after the start of chemotherapy. The expert panel really talks about the possibility, and it's been talked about here yesterday, doing ovarian tissue cryopreservation after chemotherapy has started, particularly in patients who maybe have disease where you'd be worried that the ovaries are involved. And then I was really happy to see, as someone who does a lot of survivorship work, that the post-therapy period was identified for both ASCO and ASRM. A little bit of a different focus, so ASCO talks a little bit more about talking about fertility preservation. ASRM talks a little bit more about, which I think is so important and we kind of forget to talk about sometimes, like all that stuff that you banked, like you might need to use at some point, and what does that look like, and when are we sort of talking about that? But again, this idea that really, and as a pediatrician, for me, survivorship is actually a time where I think fertility preservation is a really important thing to consider because, patients may have been prepubertal at diagnosis, didn't really have too many options. They're not going to go into acute ovarian failure, but they may be at risk for premature menopause, and they can bank eggs in their teens or 20s if, they're planning to go to medical school and, not have kids for a while. So, it's a really important discussion that we have. So who should be involved in counseling and decision-making? And I actually thought this was really fascinating. So ASCO says, in terms of, this is specifically about oncology healthcare providers, all oncologic healthcare providers should be prepared to discuss infertility as a potential risk of therapy. ASRM says all oncologists should be aware of the adverse effects of treatment on fertility and of ways to minimize those effects. So I don't know if it seems subtle or not, but the oncologists, right, the lens that we look at is really like, this is the therapy. Here, you have this cancer. I mean, there's some, variability, but especially in pediatrics, this is the treatment that we use for this type of cancer because these are the outcomes that we have. And ASRM is really saying, and they say this more specifically in the guidelines, you should think about if there are things that are going to be potentially gonadotoxic and this individual patient is really worried about that, not doing that thing and maybe doing something else. And that's a really different lens to think about. And I think, we sort of all come here together in the room, but I think that there continues to really be, in a way that I think is natural and kind of makes sense, these different lenses that reproductive endocrinology or urology has with oncology in terms of when you talk to people, what you talk to them about, what the role of a given amount of therapy is going to be. And I think the onus is just really on us to own that and to say, I have a particular lens that I look at this with. And this middle picture is the gatekeepers, right? Because I think there is truth. I think it's definitely a perception, but it's a real one on the reproductive endocrinology side that the oncologists are really the gatekeepers. And they're the ones who are going to either allow or not allow patients to have access to these services. And I think, again, we really have to sort of own that and understand what that means. And that ultimately what we really want to do, right, is be working together and figure out how we do that. But I thought that the discussion of the role of oncologists in these two manuscripts was really, when you look at it, quite distinct. So reproductive healthcare providers, so ASCO says patients who express an interest or ambivalence or uncertainty should be referred to reproductive specialists, and ASRM says main role is counseling and providing preservation. So again, I think, there's a little bit in the ASCO guidelines too of kind of the people who do the work to do the preservation, and ASRM really focuses more on the counseling aspect. And then psychosocial team members, so when someone's distressed about potential infertility, but I really like what ASRM has to say, which is that a collaborative multidisciplinary team approach is encouraged, and I think everybody here would agree with that. So what are some ethical and logistical aspects? So ASRM goes into this much more than ASCO does, again, in this current iteration. They just really say, we need to talk about the stored gametes, embryos, and gonadal tissue in terms of what's going to happen to them if the patient dies or other events occur. So, there certainly have been, and it was raised yesterday, lawsuits related to changes in relationship status. And what are we going to do about that? Minors, this is a really important issue for them because they need to really take on, more of the responsibility when they reach the age of majority. So specifically with minors with cancer, that it's agreed that parents, although even with things that are experimental, where we're not sure what the outcomes are going to be, that they can act to preserve the fertility of their children, that children are really part of this discussion, and their assent should be obtained if they're in a cognitive space where that could happen. And that unless there's really something that's been specified otherwise, that the gametes should be discarded if a child doesn't survive to adulthood. And I'm sure for those of you, who do the counseling part of this, we've all had fascinating conversations about plans for stored tissue. And then I was just so happy to see this, and I think something that we all really need to remember, and Dr. Quinn has, written an article that says, it basically, if it's not in the chart, it didn't happen, right? So we really need to make sure, for a whole lot of reasons, that we're documenting this in the chart. So moving forward, what do we think sort of guidelines 2023 could look like? A lot of the time, there's really no discussion of the difference between acute ovarian failure and premature ovarian insufficiency, and those are really very different things, very different risks, potentially come with very different recommendations for women and girls. Again, these genetic factors, I think, are going to come up more. The whole issue of the gonadotropin-releasing hormone agonists in populations other than early-stage breast cancer. Where are we moving with cryopreservation? Is it going to lose its experimental label? And then this is where I always think like not actually finishing my slides until 2 minutes before I have to give the talk is good, because I didn't have importance of a navigator on here before until Kristen's and Jenna's talk. And that really doesn't show up. And I think, again, other than the money issue, and so just having somebody put this through the system, especially in light of the money issue, is just so critical. So these are my public service announcements. So I do work with the ECHO group, and this was mentioned before. So for those individuals, psychologists, social workers, still nurses, nurse practitioners, physician's assistants who want to become more knowledgeable and involved in fertility preservation, there is a course. This is the website up here. It's really great. And secondly, so Joyce, and this was also mentioned, this is also the 2 minutes before the slides go in. This is Fertility Scout. So basically what it does is it has a map of the country. You put in what you're looking for, and it pulls up places that are near you. And then you can see here there's portals both for patients and for healthcare professionals to be able to access the different sites that offer these services. So that's my viral vector. That's why I have the cold. And he also a thank you also to all the reproductive endocrinologists here, because he's an IVF baby, because I'm bona fide gray hair, and one of the best things in my life. So thank you.